Good morning. Major Holland was unable to be here today due to a recent addition in his family. That's okay. I'm Jason Fluke. I'm a PGY 13. I'll be presenting this data from SAMC regarding our revisional data converting band to sleeve or gastric bypass. We have no relevant financial disclosures to discuss this morning. So initially, laparoscopic adjustable gastric banding was a very promising weight loss surgery option, very low short-term morbidity and mortality, and it really took hold early. However, big drop in the implementation and the frequency of its use, as you see here, from 24% of U.S. weight loss operations in 2008 down to less than 1% in 2014. And even though we still mention it in our intake seminar, it's an operation we no longer perform at our institution. In 2014, in the U.S., 60.7% of weight loss operations were the gastric sleeve, the gastric bypass at 37%, and at SAMC, pretty similar numbers, with sleeve comprising 70% of our initial operations, gastric bypass 25%, and about 5% of revisions from vertical banded gastroplasty and other operations. It's been well documented that within the first 7 to 10 years, between 35 and 50% of bands are removed for a variety of reasons, most including just poor tolerance to the band, poor weight loss, or weight regain after initial weight loss. And so we know that patients, after having the band removed, often gain the majority of the weight that was lost. So a lot of our patients inquire as to what is the best next step. Should they undergo a revision, or should they simply undergo medical management and other non-surgical options? So in our institution, we do offer sleeve and gastric bypass as revisions, and so we wanted to look at our weight loss and safety data to have better information to counsel our patients. So several studies have established the safety and effectiveness of conversion of a band to either a sleeve or gastric bypass. Many authors advocate the two-stage solution, whereas the band is removed initially and subsequent operation, the conversion occurs. I know that's the practice at some of our MTFs. And also, people have demonstrated that the one-stage operation where the band is removed and the conversion takes place at the index operation. Percent estimated weight loss varies among studies, with average weight loss in the 40 to 70% range at 12 months. Some studies have shown the gastric bypass is superior in its weight loss. Others have shown the sleeve to be superior. As expected, in most revisional operations, complication rates are expected to be higher, and it's no different in bariatric operations. A 2000 series demonstrated a sleeve leak rate as high as 5.5%, and a gastric bypass anastomotic leak rate as high as 7.5%. Both of these are obviously much higher than you would expect in an initial sleeve or gastric bypass. So our study design was simple. This is a single military treatment facility review. It was an IRB-approved retrospective chart review, and the treatment arm was non-randomized. It was a result of the patient and surgeon discussion and preference. Our patients underwent the revisional operation between 2009 and 2013, and all had the band revised to either a sleeve gastrectomy or gastric bypass. We looked at percentage of excess weight loss, complications, try to look at comorbidity resolution, and compiled these. Very briefly, our methods are not unlike most others. We performed all these cases laparoscopically, and we do the one-stage operation, as was the case in all of these operations. We use a 36 French blunt tip bougie for our sleeve and start approximately 4 to 6 centimeters proximal to the pylorus with our initial staple line. The gastric bypass, the gastrojejunectomy, was performed according to surgeon preference and training, with various methods used as seen there. We typically use intraoperative leak tests by upper endoscopy to ensure patency of the gastrojejunal anastomosis, to check for a leak, and to make sure there's no significant other abnormalities. And we have pretty standard follow-up for these patients. The demographic data is listed here in this table. We did identify 45 patients over the 3.5-year period who underwent a band revision to another operation. As you can see, only 11 of these were band to bypass, and 34 were band to sleeve. There's no difference in age. The pre-revision weights in each group corresponded with an approximately 40.0 BMI, which is not listed on the table. And you can see the comorbidities listed here. So this is the main results table focusing on the estimated weight loss. In each of these categories, the gastric bypass is listed above the sleeve. Here you see it at 1 month, about 21% in each group. At 3 months, about 36% in the bypass and 33% in the sleeve. At 6 months, you start to see a major divergence of the weight loss with 50% in the gastric bypass and 36% in the sleeve. And at 12 months, the divergence is more significant with 57% of weight loss in the bypass group and only 33% in the sleeve, actually an overall weight increase in the sleeve group. So this line is recapping the data, significantly more weight loss in the band to bypass group and 57% versus 33% with a pretty significant deviation around the mean. Complication rates, fortunately, were very low. We had 1 patient in the band to bypass group. Again, there's only 11 of those patients who underwent percutaneous drainage of hematoma. And the band to sleeve had 1 patient who underwent repeat unplanned return to the operating room with laparoscopic evacuation of hematoma from a staple line bleed. No leaks in either group. And similar comorbidity resolution rates were detected. However, with a small bypass group, it's difficult to make any meaningful results from that. So certainly multiple study limitations. There's multiple surgeons, probably 9 or 10 surgeons over the course of the study, and so heterogeneous treatment, even as we aim to standardize our approaches. I think this, in my opinion, is the biggest question is that, this initial 45 cases really included our earliest sleeve experience. Since that time, since 2013, we've had another 45 band revisions to other operations, and we're currently looking at that. My expectation is that the sleeve weight loss will be much higher than the 33%, as I feel like we've gotten more experience making these a little tighter and more cylindrical in shape, but that'll be seen in our next data report. Certainly the non-randomized treatment arm exposes selection bias, and it was a short follow-up at 12 months. We're looking at our longer-term data now. I appreciate your attention and time, and certainly welcome any questions that you might have. Thank you.
Thank you. That was a great study. And I think your findings kind of mirror what a lot of the other findings have shown. And I guess my question is then, who do you offer? And I'm sorry if I missed it. Who do you offer a band to a sleeve versus a band to bypass? Because if you do get, say, in the next 45 patients, you have an improved weight loss in the sleeves. However, statistically, the bypass is better. How do you make that difference, and who do you offer it to? Do you leave it to patient choice? Or?
Yeah, no, that's a great point. To me, the biggest value of this study is just simply helping to counsel the patient. When I have numbers, I can say, hey, we recently looked at like when we initially looked at our sleeve data and found our weight loss. I could say, hey, this is our weight loss at our institution. So when I counsel a patient who is ready to have their band removed for different reasons, I can say, we have seen in our institution that bypass does have significantly more weight loss. This is what I would expect on the median. Yours would be. So still, it is patient-driven. I mean, patients, especially as the bariatric patients are among the most educated of our surgical patients, and they have contacts, they have friends who've had each done, and ultimately come to their own decision. Unless there's some other specific medical indication why a bypass may be better, for instance, brittle diabetes, bad reflux, esophagitis, Barrett's esophagus. In general, I'll still go with what the patient prefers, unless I have a compelling reason to do otherwise.
Yeah, and I think that's what we do too. But I applaud studies like this is something that we can point to and give them actual data so that they can make the decision. So thank you.
Thank you.
Quick question. I know you're just down the hallway from me, Jason. So do you guys look at the functional activity of your patients between the two groups also? And how much that contributes to their overall weight loss too?
So when you're saying functional activity, you mean
like
aerobic exercise, not
right.
just walking?
Correct.
Yeah. You know, that's not something that we looked at, and I imagine even if we attempted to look at that, it'd be very difficult to get objective data on that. You know, certainly I think that's the, you know, we do a very good job of our nutritional education. We do a very, I think, biasly, we do a great job of surgery, but I think the X factor that we don't do a great job is really helping these people engage in true aerobic activity, something that we've been trying to do more and more. But ultimately, if a patient doesn't embrace that really active lifestyle, then their weight loss, regardless of the operation, is going to be suboptimal. Thank you.